Good afternoon. Good afternoon. We're going to start promptly. My watch says 1:30. So for those of you that don't know me, I'm Roxy Albrecht. I'm the president this year of this 74th annual meeting of the Southwestern Surgical Congress. Welcome to everybody. We have an exciting day planned for you today, beginning with the scientific sessions, then mini oral sessions, and then that dreaded presidential address that I'm a little bit anxious about. I'll let you know from the start. But then join us this evening for the Southwest Surgical Congress welcome reception in the exhibit hall, beginning at 6 o'clock this evening, maybe a little later if I go a little bit long, sorry. Attire is resort casual, lose the jackets, but it is cold, I know, so just be comfortable. Be sure to download the meeting app for access to the schedule, abstracts, speakers, claim your CME credits and more. CME will be available Monday. Watch for the email. And just so you know, there is a shorter time frame to get your CME in this year because we're switching from the ACS to the American Board of Surgery website to upload your CME to. So there's a little bit shorter time frame. It used to be somewhere like 5-6 months. Now it's maybe a month. All the scientific sessions are being live streamed and recorded. The recordings will be available up to 90 days after this meeting. The official meeting hashtag is hashtag Southwest SWSC, all caps, 23. It will be the Wi-Fi, and similarly, it's going to be the Wi-Fi password for this meeting. For those attending the quick shot session early tomorrow morning, please be sure to know where it's at. Some of them are up in the hacienda, some of them are down here. It's a good 5-minute walk or maybe longer. Gets a good exercise. So just look at the app and know where your quick shots are going to be. And I think that's it. Oh, there is one more thing. If you would desire to, please volunteer to participate on the ACS Surgeon Wellness Coalition. If you want to put your name in as a potential candidate to join that coalition, I think we can have one member from the Southwest Surgical. So Jill put it on the app to see if we can get anybody who's really interested in that. And then we'll have more details on that after we see the list of volunteers. So submit if you're interested in that in the Wellness Coalition. So Dr. Cornwell will be with us tomorrow. He had a conflicting meeting today. So Dr. Kalps and I are going to moderate this first session, and I'll have her make her announcements and then introduce the first paper.
Excellent. What a spectacular setting, isn't it? How cool to be here. Just for those who are not aware, we're going to have papers presented, 7 minutes for presentation, 3 minutes for the invited discussants. And if you would, the discussant, if you would step to the microphone and say who you are and where you're from, questions, and then we'll have 5 minutes for Q&A from the audience. And when you get to the microphone, if you would, please say who you are and where you're from so all of us can get to know each other. And if anyone lost a pair of sunglasses this morning, they are at the registration desk. So let's go ahead and get started. Our first paper. I don't see anybody moving towards, oh, here we go. All right, okay, good. I was like, wow, this is good. Help a mother out, the impact of acute care surgeon response in postpartum hemorrhage. Presenter is Dr. Lee. Come on up. Got you there. All right, I'll start you on the timer.
Great, thank you. I would like to thank Doctors Albrecht, Kalps, and Schreier, members and guests for the opportunity to present our work. I have no disclosures. Postpartum hemorrhage is a leading cause of maternal morbidity and mortality in the United States. Hemorrhage accounts for 1/3 of the maternal deaths in the United States. Early recognition and treatment could potentially prevent maternal deaths. Initial management of postpartum hemorrhage starts with manual uterine massage and pharmacologic treatments such as uterotonic agents. One may place intrauterine device such as balloon tamponade. And if these measures fail, radiologic embolization or surgical control of bleeding is indicated. Code-wide activation is a hospital-wide alert for postpartum hemorrhage that was implemented in 2015. It streamlines care and mobilizes various resources for obstetric patients experiencing hemorrhage. Code-wide activation can be activated by any of the team members when a patient loses more than 1,500 cc of blood loss with ongoing bleeding or vital sign changes. The team member dials 811 and state code-wide facility, location, department, unit number, and this activates code white in the hospital overhead, and notification page is sent to the code response team. In 2017, acute care surgeons were added to code white activation to improve maternal mortality. Acute care surgeons could be a valuable resource in the management of postpartum hemorrhage, as they have expertise in managing hemorrhage and could apply the concept of damage control resuscitation to treat obstetric patients experiencing significant bleeding. However, our preliminary analysis did not show significant reduction in maternal mortality. And in 2020, multidisciplinary postpartum hemorrhage training was created in collaboration with OB, anesthesia, and acute care surgery departments. It consisted of 2 workshops focusing on didactic education of postpartum hemorrhage, team communication. Acute care surgeons gave lectures on hemorrhage control and participated in small group simulation for clinical scenarios. There were also workshops to improve technical skills. The code-wide activation is a rapid multidisciplinary obstetric hemorrhage response team constituting OB surgeon, anesthesiologist, acute care surgeon, and nurses from various departments, including OB, mother-baby unit, ICU, and nursing supervisor, and OR surgical tech, and when available, pharmacist, and the regular OR staff, and spiritual care respond to the code-wide activation. The purpose of this study was to evaluate the impact of acute care surgeon involvement and multidisciplinary postpartum hemorrhage training on maternal outcomes. UC Health Memorial Hospital has 2 campuses located in Colorado Springs. Central Campus is the ACS Verified Level 1 Trauma Center, and North Campus is ACS Verified Level 3 Trauma Center. At these 2 centers, birth centers deliver about 4,500 babies annually. A retrospective review was performed on all code-wide activations from April 2015 to August 2022. 3 groups were compared based on the interventions: pre-ACS response team, ACS response group, and the ACS response and training groups. ICD-10 codes denoting postpartum hemorrhage was utilized to identify patients who had code-wide activations. Electronic medical records were reviewed to identify variables listed in the slides. Over the 89-month study period, a total of 218 patients were identified. Among the 3 groups, there were no differences in age, gravida, delivery type, and placental abnormalities. The addition of ACS to the code-wide activation increased TXA administration, NTP activations. There were no differences in time to TXA or MTP. Over the study period, the transfusion requirement decreased with the ACS response and training group receiving the lowest number of packed red cells, FFP, and platelet. We also looked at the laboratory values, and there were no differences in pre-code-wide activation laboratory values except for the pre-INR that was the highest in the pre-ACS response. There was no difference in the post-hemoglobin count. However, the pre-ACS response group had the highest INR and the lowest platelet and fibrinogen counts. The addition of ACS to the code-wide activation increased ACS presence with the shortest amount of response time, and the operative duration decreased over the study period. There was no difference in the hysterectomy rate, and hospital length of stay was similar. The ICU length of stay was slightly increased in the ACS response group. Most importantly, the mortality rate went from 17.9% in the pre-ACS response group to 2.4% in the ACS response, then 0 in the ACS response and training group. So in summary, the involvement of acute care surgeon in the management of severe postpartum hemorrhage increased the use of TXA and MTP activation. It was also associated with faster hemorrhage control and correction of coagulopathy. The combination of acute care surgeons and multidisciplinary postpartum hemorrhage training improved maternal mortality. In conclusion, a maternal mortality is best served by multidisciplinary response, and our data suggests that addition of acute care surgeons in the hemorrhage response team and multidisciplinary postpartum hemorrhage training benefits the patients. I'd like to thank Southwestern Surgical Congress to the opportunity to present at this beautiful resort, and I will now take questions.
And before Dr. Schur has a chance to get started on her discussion, we should also point out that this is a paper that's in consideration for the Jack Barney Award. That's awarded to the best resident or medical student or fellow paper. So also in consideration.
Hi, I'm Liz Scher. I'm from UT Health San Antonio. I think you did a great job. I think it's a tall order to present the first paper. I think you did a really excellent job. Thanks for the Southwestern Surgical for the privilege of discussing this important work, and thank you to the authors providing it well in advance of this meeting. Congratulations on well-done retrospective review of the implementation of acute care surgeon response to and stimulation-based education regarding code Y activation for multidisciplinary management of postpartum hemorrhage. I have several questions. So your data would suggest that involving the acute care surgeon resulted in more frequent activation of MTP and administration of TXA. Do you think that these interventions could be protocolized, or do you think actually having the acute care surgeon present resulted in different intraoperative decision-making? Do you have any more information about the intraoperative strategies used by for these patients who had the acute care surgeons present? Does your MTP include whole blood? If so, at what point during the time period was whole blood introduced for this patient population? And finally, have you all considered using preoperative placement of Reboa or Access for previously identified placenta accreta spectrum patients? And it could be done by acute care surgeons or interventional radiologists. Again, excellent job. Thank you so much for the opportunity to speak.
Thank you for the feedback and questions. To address your first question about the TXA and MTP being protocolized, initially it was not part of the protocol, but now over the study period, we have implemented that MTP is activated as part of the code-wide activations. And regarding the ACS present, we think that the presence of ACS offer the insight into the depth of the patient's shock and management of their resuscitation. And regards to the intraoperative decision-making, the data point we have from our study is that the involvement of ACS and then further training show that the operative duration has decreased, more in line with performing a damage control surgery. In regards to your whole blood, we currently do not use whole blood for the postpartum patients. We do use it for trauma activation, but the whole blood is not used in the pregnant patients yet. And then Reboa is also it's not part of the code-wide activations yet, but it is something to consider. Thank you.
Hey, Chad Hall from Temple, Texas. I'm just curious, being an ACS surgeon myself, what I'd have to offer in the room. So I'm curious what your endpoints of resuscitation were. Was TEG used to, was that used to give TXA? So I found it interesting at higher MTP activations, but actually lower blood utilization. So just curious about that. And also the 17% mortality in the pre-implementation seemed really high. I'd like to think that I could improve survival by 15%. But I just don't want to be that confident if I just walk into the room. So I'm curious if you've looked into those mortalities in more detail.
So regards to TEG is utilized by the ACS surgeons, and based on the OB hemorrhage guideline, TXA is usually given, should be given before. It's one of the step ones to give. So I don't think whether to give TXA or not is dictated by TEG values, because a lot of times it's usually given ahead of time. And regarding the mortality, So if you look in the slides, the high mortality rate could also be that we looked at only the code-wide activations. So among the first pre-ACS response group had 28 patients, and among those 5 patients had mortality. So I think that kind of increases the rate of the mortality. And over time, as we did more training and education, in a similar amount of time, we had a lot more code-wide activations, increasing the denominator.
Good afternoon, Alexander Colonna, Salt Lake City, Utah. A similar question about the mortality numbers. Just looking at your group of 28 patients in that pre-activation, can you, to build on the other questions, can you go back and look prior to the code white system, if you could identify similar patients and see what their mortality was? Because I mean, you have 28 patients versus 190, and I think that may be skewing your numbers. And maybe your mortality was even worse before doing the code white activations, but I think that would add to the strength of your manuscript. Otherwise, great job.
All right, thank you for the feedback. That's a great point.
Thank you, Justin Regner, Temple. When you did the education, did y'all do simulations in the OR? How did you go about that process? It was in collaboration with OB, anesthesia, and acute care surgeons. I personally was not present, so I don't know the exact structures of the workshops, but I believe it was with lectures and workstations, and then kind of clinical scenarios. So y'all didn't use any like cadavers or simulation training?
That I do not believe so. The workstations kind of focus on like placing the intrauterine balloon tamponade device and getting all the supplies.
Okay, thank you.
Thank you. Our next paper is also a Jack Barney Award finalist. Also gets the award for the longest title. I can say that because it's from OU. I wouldn't pick on anybody else, but get on board or get out of the way. Survey shows all residents have exposure to robotic surgery platforms, yet no formalized curricula exist. A Southwest Surgical Congress multi-center trial. And presented by Dr. Chris Jeffrey.
Thank you, Dr. Albrecht. Thank you, Dr. Copps, for moderating this session. Thank you for the opportunity to present our research here today. So yeah, I'm Christopher Jeffrey. I'm a general surgery resident at University of Oklahoma. So I will abbreviate that title really quickly and say that the survey shows all residents have exposure to robotic surgery, yet we have no formal curricula that exist among programs. Neither myself nor the co-authors have any financial disclosures. So a little bit of background. In 2020 alone, approximately 1.2 million robotic assisted surgeries were performed worldwide. More than 70% of those were done in the United States, about 800,000. General surgeons are now the highest volume users of robot assisted surgery platforms, and general surgery trainees are being ever more exposed to this in their training. So objectives, we wanted to assess the current exposure to robotic surgery for general surgery residents, to assess the presence or absence of curricula among programs, and if a curriculum was present, to evaluate the elements of that curriculum. Furthermore, we wanted to identify opportunities for trainees and training programs regarding robotic assisted surgery. So our methods, we sent a survey out to member institutions of the Southwest Surgical Congress after approval. This was filled out by robotic directors and or the residency program directors. All responses were anonymous. Data was de-identified prior to descriptive analysis. So here's a sample of our survey. I won't go through all of this, but I'll bring your attention to about 4 questions here that I'll address on the next slide. So do you think that training in robotic surgery is important for general surgery residents? Do your residents participate in robotic surgery cases? Is there a formal curriculum? And does your program offer any formal recognition of curriculum completion? So we found in our selected results here that all general surgery residents are exposed to robotic surgery. It's 100%. We did have an N of 28. Training was important for residents in 89% of our respondents, and that there was a presence of a curriculum in 86% of respondents. And then at the end there, that there is a only a recognition of completion of about 54%. So although residents are participating in these curricula, they are not actually being recognized for their completion. The makeup of our respondents is about 75% were university affiliated and the remaining 25% were independent. Additionally, we wanted to look at the elements of the reported curricula. So a majority of programs reported utilizing simulation, directed console training, and case observation, and other elements included were cadaver, live animal lab, and videos were used to a much lesser degree. So as far as exposure to types of cases, the main cases that residents were exposed to were biliary hernia and colorectal, which is consistent with national trends in the use of robotic surgery. Interestingly, if you look at the other side of things, there was a program or two that responded saying that they utilized the robot in transplant and trauma surgery. We're seeing more use and more creative uses of the robot in many elements or many types of surgeries and disciplines. So as far as exposure throughout residency, 65% of programs reported earliest exposure in the first year of clinical training, 33% in that second year. And then the majority of robot assisted cases were done in the fourth and fifth year of training. So to summarize that is that all the residents are experiencing robotic surgery in all 5 years of general surgery training. So in conclusion, all residents are exposed to robot assisted surgery. 80% of residents log more than 20 cases by the time they graduate, and there is no formalized curriculum. And those that do exist significantly vary by their components. So currently it's difficult to assess competency or equivalency of surgical graduates with the current methods. So our next steps, we would advocate for a formal recognition of robotic surgery as an important component of surgical education, and then furthermore develop a formal curriculum to establish equivalency for surgical trainees akin to FES or FLS. Of course, there are limitations to our study. This is inherent to the use of a survey-based methodology. This is cross-sectional in nature. We are geographically limited to the Southwest Surgical Congress members, and we cannot guarantee that all programs responded. But the N of 28 small and is a small representative of all general surgery programs. So there's some sources, and then thank you for your time.
Our invited discussant is Dan Dent from UT San Antonio.
Thank you. And thanks for getting the manuscript to me in a timely manner.
Yes.
So I'm not going to summarize the manuscript, but I will say that the data here are essentially no change from a 2019 publication from the Harvard UCLA group.
Yes.
That was probably some overlap in the Venn diagram of who responded.
Yes.
And suggests that this, relative to other publications in surgical education, this is a pretty reasonable sample. And I suspect it's an overestimation of both experience and curricular expectations, because the programs that respond typically are high resource programs that are interested in the topic. And most program directors, I think, overestimate what their residents are doing when they are getting a little defensive filling out a survey about what do I have in my program.
Sure.
With that said, I have a few questions. Did you do a actual statistical comparison to previous literature and show that really things have not changed in the last 4 or 5 years in terms of robot curricula? And then second question is kind of multifaceted, which is, can you speculate about the impact of industry involvement in robotic education? Does the existence of a certificate from Intuitive, is that really a disincentive to the development of curricula or standards across our surgical education space? Or is it substantial enough that people don't see a need to develop a more robust or non-industry associated curriculum?
Thank you for your questions and feedback. So the first part of your question, as far as did we do a statistical analysis against the previous literature? No, we did not. I know those numbers pretty well off the top of my head. I can tell you that they're pretty similar. I don't have a statistical test to tell you, but the study you're referring to from that was submitted in 2018 by Dr. Tom, who was actually presented earlier this morning. So I'll hopefully have an opportunity to talk to her about it. But looked at the country overall, and they surveyed about 277 programs, and they had a 50% response rate, and they broke it down geographically. And if you look at it geographically in the West, which is similar to our cohort that we looked at, the proportions were almost identical. And so I think what's interesting about that is the fact that we are 5 years later, still dealing with the same problem of not having a formal recognition program or curriculum to identify competency in the residents. So I think that says something, that this has been looked at multiple times over the years. The initial study that looked at this was in the early 2000s regarding robotic surgery. And as you can imagine, the numbers have changed significantly from 2002 to about 2018. But since 2018, it's about the same, and we've leveled off, and we still haven't developed a curriculum. As far as Intuitive's impact, it's impossible to separate Intuitive from this, as they are the ubiquitous as far as robotic surgery platforms go, and they are instrumental in the creation of a curriculum early on. I think at this point we need to progress away from relying on industry training and relying on Intuitive or the other systems that are coming out for training, and separate ourselves from that and develop a curriculum on our own as a surgical residency programs to establish lack of bias from the use of those systems, and assure that we get a validated system across all programs. As far as a disincentive, it's hard for me to say, is it a disincentive? I know myself, I've got an equivalency from Intuitive, but I'm not sure how ubiquitous that actually is. Is it being utilized across the board? I'm not sure. That's something maybe we could look at. Our programs relying on that to be their marker of utilization or competency. So I welcome any other questions. Hopefully that answered yours.
I have one question, Chris.
Yeah.
So in line with FLS and FES is costs
Yes.
to do the testing. And what is your,
Yeah,
it's
so-
another unfunded mandate for residency programs.
Yeah, so as far as cost goes, I think we have a lot of the groundwork already laid out. A lot of the things that were mentioned in these programs are things that we do or programs do already. They have the simulators, they have the things that are elements are already in place. We just need to recognize that it's being done. As you can see, as I mentioned, only 50% of programs are recognizing that. And maybe a way to avoid the cost part of that is to say, or to at least circumvent it, is to say, this residents are already meeting these qualifications and we recognize that they've met that in their training. Of course, that is going to be left up to a little bit of subjectiveness as far as who is evaluating that. But I think it's important as it's become such an important part of our training.
Thank you. Thank you.
Our next paper will be Patient Characteristics of Single Port Appendectomy and Outcomes in Pediatric Patients, to be presented by Matthew Kelly. Is that even close?
Kelly, yeah.
Okay.
correct.
From the University of Nevada at Las Vegas. This is also a Jack Barney paper.
Hello, and thank you for the opportunity to present. I'll just say up front, there are no disclosures to release. So to provide some background, acute appendicitis is the most common indication for abdominal surgery in the pediatric population, with approximately 70,000 operations performed annually. The classical way that this is performed is via laparoscopic appendectomy with a 3-port technique. However, in attempts to improve cosmesis, single incision techniques have been developed, 2 of which are shown below. To the right is the single incision laparoscopic appendectomy, where a three working port gloved trocar is inserted in the umbilicus, and then an appendectomy is performed either intra or extracorporeally. The one of interest in the one in this study shown below is the transumbilical laparoscopic appendectomy, where a 12mm trocar is inserted in the umbilicus, the appendix is grasped and extracorporealized, and then an appendectomy is performed. Should be of note, these studies have been shown to have decreased operative times, increased time to PO intake, and decreased overall hospital stay. However, the population of when these operations is appropriate is still somewhat unknown. So that brings me to the purpose of the study, was to evaluate patient characteristics and assess outcomes associated with transumbilical laparoscopic appendectomy compared with conventional 3-port laparoscopic appendectomy. This is a single institution retrospective review of all pediatric surgery patients from 2017 to December 2020, where we found information such as demographics, as well as presentation, preoperative, intraoperative, and postoperative outcomes. All analysis was performed with SPSS, and a p-value of less than 0.05 was considered significant. Of note, at our institution, we have 3 providers who do this technique. They do it in a uniform manner, and for the purpose of the study, they always attempt transumbilical laparoscopic appendectomy first. If they're unable to perform it, then we go to 3-port conventional laparoscopic appendectomy. The way they do this is by grasping the umbilicus with penetrating towel clamps, everting it, doing a 1 centimeter vertical incision, placing incising the fascia, placing a 12 millimeter trocar, grasping or using a 5 millimeter laparoscopic camera alongside a laparoscopic grasper to find the appendix, extracorporealize it, and then an appendectomy is performed with either an endoloop with bovial trochantery or a stapler. The cecum is then returned and the incision is closed. For our results, we evaluated 653 patients, 27% of which were able to successfully undergo transumbilical laparoscopic appendectomy. Majority of our patients were male. The average age was 11.2 years. Majority were white or Hispanic ethnicity. Majority had a healthy BMI, and the most common presenting symptoms were pain for less than 72 hours, afebrile, leukocytosis, and elevated CRP. Going through patient characteristics, we found no difference in the rate of conversion to classical laparoscopic appendectomy based on age, gender, or race. However, when looking at patients' BMI, patient with BMI greater than the 85th percentile were found to have a higher failure rate of transumbilical laparoscopic appendectomy. Furthermore, patients with pain for greater than 72 hours were found to fail transumbilical laparoscopic appendectomy. Looking at leukocytosis, CRP, and platelet count, there was no difference in the rate of conversion. Intraoperatively, 13% of our cases took less than 30 minutes to perform. However, if the cases did take longer than 30 minutes, 72% of those were classical laparoscopic appendectomy. This is consistent with the information found in the literature. Additionally, when looking at the rate of conversion to classical laparoscopic appendectomy, if a resident was present, we actually converted at a lower rate. Pre-op, post-operatively, there was no difference in readmission rates. There was a higher incidence of ileus in classical laparoscopic appendectomy, and there's no difference in post-operative wound infection. Furthermore, from this data, we found that patients with a healthy BMI, pain less than 72 hours, and patients with uncomplicated preoperative imaging findings should be considered for laparoscopic appendectomy. Age should not be a factor in determining appropriate candidate, and postoperative outcomes are similar between the 2 operations. The inclusion of a resident did not alter the conversion. Thus, this is an appropriate technique to be used at teaching institutions. Study limitations, it's retrospective, it's single institution. Our providers used a uniform surgical technique, thus alternate techniques may have alternate results. Conclusion, patients with healthy BMI, pain less than 72 hours, and specific imaging findings are candidates for transumbilical laparoscopic appendectomy. And both of these operations have similar postoperative outcomes. Thank you.
Thank you. The paper will be discussed by Dr. Alessandra Landman from the University of Oklahoma College of Medicine.
Congratulations, you're all done. Great presentation. Good job. Now you get to relax for the rest of the meeting. So
He still has to answer questions.
you do have to answer questions.
Not out of
Okay.
the woods yet.
I was super excited to see a pediatric surgery paper discussed and to have the opportunity to discuss it, especially when it's appendicitis, because it's the most common thing that we do. As you said, my group does about 600 of these a year. So we're doing at least 1 a day most days. And so I thought it was very interesting to discuss an interesting technique to perform appendectomy. As you said, 3-port appendectomy remains a standard of care. And here we reviewed a novel approach that provides potential for improved cosmesis, decreased postoperative pain, and potential cost savings by avoiding opening additional equipment. As you said, I'm not going to summarize your paper for you, but this is a retrospective single institution study, and we were looking at conventional appendectomy, comparing it to a transumbilical approach. The findings I thought were what you would expect, right? The transumbilical approach works for skinny kids that present with early appendicitis. If they're big, you're going to have a hard time finding the fascia to be able to evert the appendix out of the fascia. If they have complicated appendicitis or any findings of retrocecal appendicitis, it's going to be a longer operation because it's more difficult and you're not going to be able to do it through your transumbilical approach. So what you would expect is what I thought. I thought it was really cool that you guys presented BMI data because that hadn't been presented before. I have a couple of questions. One, I didn't see a breakdown in your paper by surgeons. So do all your surgeons practice the same and do they all have the same conversion rate from a transumbilical to a conventional appendectomy? Next question, why a stapler or an endoloop if you're everting the appendix? Why not just tie it with a Vicryl like you do for an open appendectomy, like when you do an XLAP? And then final question, how are you going to use the results of this study to change your practice back home? Thanks again and congratulations, you're all done.
Thank you. So the conversion rate, I don't have that data. Unfortunately, that's not something we looked at. We didn't pull out which surgeon was performing it. The surgeon, we have one pediatric surgeon who's been at our institution for decades now, and we have two fairly newer pediatric surgeons. So he taught them this technique. And so now it's a uniform technique because it's the way he does it. In terms of why use a stapler versus in an endoloop versus not just Vicryl, I don't have a great reason. That's something that could be looked at in the future.
Yeah, it's more cost savings,
Yeah.
really. Like an endoloop's much more expensive than a pack of Vicryl ties.
Mhm. And going forward, it'd be interesting to see our data on age. Some of the different age groups, we didn't have a very high end, but it'd be interesting to see if you could try this in even skinny adults.
Mhm. Great job,
Thank
thanks.
you.
Questions from the floor?
Shrapple, Colorado Springs. Isn't this just an open appendectomy, except you made the incision at the umbilicus instead of in McBurney's point? Second thing is, did you analyze intent to treat? Meaning, did you actually analyze the patients converted to laparoscopy as the transumbilical, or did you analyze them as laparoscopy? And then did the operative time change? Because I know that you categorize them almost in a dichotomous fashion, but when you actually look at it as a continuous fashion, what were the difference in operative times? Thank you.
So this is essentially just an open appendectomy, but one of the major differences is that as opposed to a McBurney's incision, you're going through the umbilicus and you're actually not going through muscle. And so there's, in theory, a lower rate of postoperative pain associated with this. Additionally, in a pediatric population, you can evert the umbilicus. And so when you do this operation and you close it, it's essentially scarless, which is different from an open appendectomy. Looking at the conversion rate, the way we did it uniformly here is that all of our patients are attempted with transumbilical laparoscopic appendectomy. And so they're all intended to be treated single port, and then the ones who fail go on to conventional 3-port. So there is not necessarily an intention to treat analysis because they're all intended to be transumbilical. And so, yeah.
Great presentation. John Cook from Temple, Texas. You talked about the conversion rate with increasing BMI and the difficulty of the case. Did you look at the perforation rate in those during that case? And if you had higher perforation rate and you converted to laparoscopy instead of using 3-ports instead of a single port, wouldn't that also increase your LES rate? So did that skew your data when comparing that to a single incision?
I believe it did skew our data. We do have preoperative imaging in the pediatric population. Sometimes that's in the form of an ultrasound, sometimes it's in the form of a CT scan. And we did stratify patients based on if they had, we classified it as complicated CT findings. So perforation, abscess formation, as well as the location of the appendix, if it was retrocecal versus anterior. That information sometimes is not always present in chart review though. The radiologist doesn't comment on where the appendix is, but we did classify based on complicated imaging findings. And that would lead to a higher rate of ileus.
And one more thing, it sounds like you used a wound protector and sometimes used this. Did you
We never used a wound protector. Okay. And that's one of the things that has been in the data looking out. It's been recommended because there's the theoretical risk that you're taking in infected, inflamed appendix and putting it in approximation with the skin that would lead to a higher rate of superficial surgical site infections. We didn't find that with our data.
Thank you.
Excellent presentation. My name is Izzy Obahari from Amarillo, Texas. Just two quick questions for you. You mentioned that there was a higher conversion rates when with the residents present. Is that correct?
There was a lower
Low,
conversion.
low conversion rate. So the question is, why was there a lower conversion rate? Or why do you think that it was? The second question is, with patients with higher BMI, what do you think is the reason for the higher failure rate or conversion rate with patients with higher BMI? Thank you.
With the resident present, my thought is that typically the way it works at our institution is that the resident gets the first shot to try to grab the appendix. And so if he struggles or he fails, then the attending will hop in. And so there's essentially more tries attempted, which would lead to a higher rate of success. In terms of the reason BMI caused a higher rate of failure, I think it's anatomic. Large kids with fairly large abdominal wall makes it harder to perform this operation from an anatomic standpoint.
I have a question along that lines. So middle of the road, a two-port, where all you need to do is mobilize a little bit of the cecum in those higher BMI patients with that second trocar that's suprapubic area and still cosmetic because it's in the hairline.
Definitely something to consider. Very interesting idea. Yeah.
Thank you very much.
Next paper is placement of intracranial pressure monitoring by non-neurosurgeons, a follow-up study. And this will be a virtual presentation to follow up with questions with Dr. Hahn, who I see is in the back over there, and will be presented by Dana Jumpa.
Before starting, I would like to make acknowledgements to Rosie Sapula for her help with our data management and storage within our research electronic data capture. First, we want to talk about traumatic brain injury, which we know is one of the most significant causes for disability and mortality amongst trauma patients. In 2020, there were over 60,000 TBI-related deaths in the United States. Patients face short and long-term consequences, not only physical, but social and cognitive and behavioral, all that which impact their daily activities and their financial independence. In severe TBI protocol, one of the procedures included is intracranial pressure monitor placement. An incision is made to the right frontal area, followed by a burr hole, and then a catheter and a bolt are placed, and then the bolt is then secured. The purpose of this study was to follow up on a previous study done at our facility and determine if there were significant differences in complications between ICP bolt placement by neurosurgeons, attending trauma physicians, and general surgery residents. This was a retrospective chart review of trauma registry and patient medical records. All the patients included were trauma patients who had ICP bolts placed from January 1st of 2012 to December 31st of 2021. Data that was collected included injury characteristics, demographics, interventions, and outcomes. In looking at patient demographics and injury severity, in total, we had 194 patients. 4 bolts were placed by neurosurgeons, 183 by general surgery residents, and 7 by attending trauma physicians. The patients included were mostly middle-aged male with high injury severity score and a low Glasgow Coma scale. From 2016 to 2021, there were no bolts placed by attending trauma physicians. From 2019 to 2021, there were no bolts placed by neurosurgeons. In looking at head injury details, mostly were intracranial hemorrhages, including subdural, subarachnoid, intraparenchymal, intraventricular, and a small amount of epidural. The reason why the percentages add up to greater than 100 is because it can be mixed in one case. In looking at ICP-related data, we looked at opening pressures and monitoring days, which was about 3 to 4. In looking at major complications during procedures, there was none noted in the 3 groups. In minor complications during the procedure, There were 5 device malfunctions and 1 inaccurate reading. All were in the general surgery resident group. In complications after the procedure, there was 1 central nervous system infection, 3 mechanical problems, including 1 inaccurate reading, 1 dislodgement, and 1 malfunction. In looking at complications, there was no statistically significant differences in the 3 groups. In outcomes, we looked at ICU length of stay, vent days, hospital length of stay, and mortality. There was no statistically significant differences in the 3 groups. We know that there is an increasing demand for neurosurgeons, but we also know that there is a downtrend in those entering the specialty. And 57% of those in the specialty have already been practicing for over 20 years. We also know that neurosurgery practices tend to cluster around urban areas. In 18.5% of level 1 trauma centers in the Midwest, there are less than 3 neurosurgeons. In 58% of level 1 trauma centers in the South, there are less than 3 neurosurgeons. I'm looking at trauma quality improvement program. The ICP insertion time averaged about 2 hours for our facility. The documented average nationally is 4 hours. We also know that trauma attending physicians have been able to place it safely and effectively. And with the appropriate training, mid-level practitioners have been able to place ICP bolts safely. At our facility, the general surgery residents have been placing it since the 1990s with minimal complications, with neurosurgery consultation and supervision by an attending trauma physician or a trained chief resident. So ICP monitors can be placed by general surgery residents and attending trauma physicians with minimal adverse effects. And ICP monitor bolts can be placed in faster times where surgery residents are allowed to conduct this procedure. So ICP monitor bolt placement should be included in the core clinical skills for surgical resident training. Thank you for your time.
Our invited discussant is Dr. Clay Cothran-Burlew from Denver.
Thank you. Thank you very much. This is a retrospective study of 194 patients evaluating the safety of ICP monitor placement by non-neurosurgeons. This report builds upon prior work by the authors published in 2012 in the Journal of Trauma. I congratulate the authors via Dr. Hahn, who's over there. There you are. I congratulate the authors on questioning historical territory, for lack of a better phrase or wording, and in evaluating that territory, deciding whether or not a bedside procedure could be performed by the most available clinician. The importance of this work is particularly salient as we face shortages of neurosurgeons. While many critical care intensivists feel comfortable managing intracranial hypertension, often with or without the concert of the input from our neurosurgery colleagues, utilizing in-house teams to place monitors that can then be managed with on-call but off-site neurosurgeons may be a critical step in preserving the workforce. I have actually now 4 questions. It was just 3, but okay, 4, sorry. Number 1, could you clarify a little bit of the training and the credentialing process? How exactly are interns versus residents versus chiefs classified? How do you become a skilled chief that is allowed to supervise the younger residents? Are these cases proctored and then documented so you can keep track of who has gone through the credentialing process? And then finally, if the trauma surgeons are part of this workforce, how are they also being credentialed and sort of maintaining their own certification at this procedure? Number 2, the picture that was shown up there, this is my new picture, my new question, sorry, seems much more invasive than what I remember when I used to place ICP monitors many moons ago as a stab incision in this little handheld drill that we would sort of hope that we were in the right place and pop in and put the monitor in. So I'm curious whether or not that picture that was up in the slides is really representative, or if it's something a little closer to this little tiny stab incision that I recall when we place monitors. The third question, more globally, who provides coverage for neurosurgical patients during the day and at night? Is there anyone in-house, or is it only general surgery residents in the ICU, or are there neurosurgery residents or neurosurgery APPs as part of your workforce. And then finally, sorry,
You're going to make me remember all that, right? Okay.
you can have this.
Okay.
Finally, how does this fit into the paradigm of regional trauma care? Is this only a mechanism to prevent burnout in our neurosurgeons, or are you suggesting that some TBI patients could be managed in more rural locations without transfer to a level 1 facility? Very nicely presented study on a pertinent topic in today's ever-changing landscape. Thank you.
Okay, thank you, Claire. All right. Well, to address these questions, and this has been an evolution. To put it in perspective, I actually took over the system that was already in place in 2008, and it was a big surprise for me coming from shock trauma, where a third-year neurosurgical resident came, put in the bolt. I would beg them to let the intern do it so they get some experience, and then show up there and say, "Hey, you're putting in bolts now." I was like, "Okay, I haven't directly done that." So the attending part is it's supervised by another attending. We haven't had a lot of turnover, so it hasn't come up much. From the resident top to bottom, generally it's the second years, unless the second year has done a tremendous number of them in their ICU rotation. The second year is more or less stationed in the ICU. They help with the resuscitations that aren't high acuity while the chief watches or the attending watches. And then the really sick ones are obviously the attending and the chief. And I don't have hard data other than after about 3, if they look like they know what they're doing, we sign them off and they can be independent, move into more of the supervisory role. There are rare instances, I've been there 15 years, but a few people I can think of after 3, I was still not comfortable. And those are the ones that say maybe I ought to do 1 or 2 more. The biggest difference is we're shifting over this year because not everyone, a lot of the people who grew up with the do one, see one, teach one idea, I guess that's where we got 3, with a different idea, which we're actually going to use cadavers. Initially, I was trying to do it because we have a large cattle population. I won't get into the nastiness, but going to the slaughterhouses, those skulls are not useful for intracranial pressure monitoring because they're kind of shattered. But that's sort of the global idea of how you would get about how you would teach them and how you'd bring through. I'll be perfectly honest. I'm more worried about a resident going off in the middle of the night and putting in the central line than I am doing a bolt. And you can see the numbers, it's just far more frightening as far as your complications and what can happen. As far as the regional, that's an interesting question. We haven't gotten very far with it, but theoretically, Kansas, we generally teach in Wichita that people go off and practice. And a lot of times they are the trauma service out in Hayes or Liberal or other, decent sized towns, but don't have that capability and certainly don't have a neurosurgeon. I don't know that I've convinced any yet. I mean, theoretically, there are a number of people who are perfectly competent to put in bolts in these smaller towns and already know the general idea of basic management or at least stabilization. It's sort of a similar idea that they can place Roboas and hopefully stabilize. We just haven't made that jump to that level. I can tell you probably the biggest one is the hospitals. The hospitals are not very excited about that level of acuity staying in a level 3 or lower trauma center. But I think we'll have to. I mean, the other thing to put in perspective, everybody's aging, myself included. I started with 6 dedicated trauma surgeons. Now there's 3 of us that are dedicated with some burn surgeons happening and helping. When I started, we had 8 neurosurgeons. We're down to 5. And one of them is young and another one is somewhat young. And the other 3 are kind of like me, not so young. We're mid-career or moving on. So I think we need to address this because we're not getting the giant push of new neurosurgeons entering the pipeline. So this is only going to get worse and worse. And realistically, I don't know why we're having the discussion. I've got to say that this data has been solid for a long time. We're talking almost 30 years in this particular program, 2 different large centers. There's lots of people who are doing it, but for the people who don't do this, I don't understand why we're not already doing it. You should have control of your own thing. And truthfully, you're the same thing. I guess Grace is here. I won't pick on you, but the usual thing, you're the one who's actually managing the brain injury. The neurosurgeons are there to clean out some clot, and that's about it. And that's going to be their level of involvement. They look at the pictures on that, say that's survivable, not survivable. Bolt would help out. We're on board for this, whatever you say, then we put in the bolt and call them back. This was the magic number you've got. So to get that started 2 hours earlier, I don't understand why you wouldn't do that. It just makes perfect sense. And you're already there, whereas they're at home. All of our guys are private practice. There is no neurosurgical residency whatsoever. So you're asking a person who might be doing a spine somewhere, or there's 2 level 1s, might be doing a craniate, another one. Deactivate the backup center just to put in a bolt, or do you put in the bolt and then see if you need somebody to come and do a craniate and activate the backup center? Yes, sir.
David Young, retired in Santa Fe, New Mexico. I'm understanding that these are all bolts. When an intraventricular monitor is needed, I would assume the neurosurgeon makes that decision, but a neurosurgeon in bed at 2 o'clock in the morning might default to someone else putting in the bolt rather than getting out of bed and getting into the hospital. Can you discuss that?
Sure. We haven't had a real problem with that. Generally, our algorithm is for pressure monitoring. We don't use the ventriculostomies for pressure drainage that often. It's usually people with some element of hydrocephalus and enough interventricular hemorrhage, we think it's going to block the system. Haven't really had a problem with them coming in. The first one was to teach us how to do ventriculostomies. And I said, I don't want to learn how to do ventriculostomies. I don't think any of us as practitioners are going to do enough of them that I think it's a good idea. A bolt has relatively, I wouldn't want to call it minor, but from our studies have been at least relatively minor complication rates. I think when you move it up to a bolt, then the neurosurgeon needs to be at bedside and they need to be placing it. And the volume isn't very high, but so they've been okay with that up to this point. I know that in the past, when we had a stroke program that had a neurointensivist, they actually did put in their own ventriculostomies, and they had the same thing trying to get us to do them. I just think when you take 6 and we're going up to 7, 8 categoricals, and then the attendings, you're just diluting out the experience to the point that I just see something bad would happen. I'm not saying that in a bigger program, maybe you could, but in a hybrid program that's an affiliate, I don't think that's a good idea. I don't think you'll have your core competencies used enough to be competent in doing that particular procedure, but that's my personal opinion.
Other questions?
All right.
Thank
Thank you
you.
to Congress. Thank you for this hybrid thing. I really appreciate that.
Okay. Our next paper will be pre-hospital end-tidal CO2 is predictive of death in intubated and non-intubated patients, to be presented by Ms. Courtney Wham, who comes to us from Denver Health Medical Center. Ms. Wham.
Does the green one move the slide? It's my first conference. Yeah. Okay, great. All right. Hi, my name is Courtney Wham. I've been a paramedic at Denver Health since 2015. I'm also in my 3rd year of medical school at the University of Colorado. I'd like to thank the Southwest Surgical Congress for giving us the opportunity to present our work here today. Our work is titled Pre-Hospital ETCO2 is Predictive of Mortality in Intubated and Non-Intubated Patients. This was a collaboration between the Ernest E. Moore Shock Trauma Center at Denver Health, the University of Colorado Department of Surgery, and the Denver Health Paramedic Division. We do not have any disclosures, and this was funded by a pilot study grant program at Denver Health. So to start with some background, pre-hospital identification of shock lacks accurate markers and has long been limited to basic vital signs and physical exam. While some EMS agencies have attempted to implement more advanced technologies like point of care butterfly ultrasound or point of care testing in the pre-hospital realm, these modalities continue to be expensive and are not widely utilized in ambulances across the nation. We would like to propose that end-tidal capnography could be a resource and a tool that is already on ambulances to identify severity in traumatic patients. So as a brief review of ETCO2, it is the amount of carbon dioxide in exhaled air. ETCO2 acts as a pretty accurate surrogate for PCO2, usually within 2 to 5 millimeters of mercury under normal physiology. However, under abnormal physiology, in things like having a VQ mismatch or abnormal ventilation, or of most interest to us, reduced cardiac output causing reduced alveolar perfusion, ETCO2 can provide objective data into patient status in the field. So just a quick review, there are 2 ways that we can obtain ETCO2 values. On the left is what I'll refer to as ILVC, or the inline ventilator circuit, through an intubated an ET tube. In an intubated patient on the right, you have the specialized nasal capnography cannula. So as a little bit of background for exactly the purpose of our study, ETCO2 devices are universal in ambulances already, as you can see here in one of the many scenic places we intubate in Denver. The gold standard of intubation confirmation is the inline ventilator circuit capnography monitoring device. We have also implemented post-chemical sedation respiratory monitoring is now protocol to place a patient on a nasal capno cannula. So again, these are already commonplace on the ambulance. Prior work by our group and other studies have shown that ETCO2 correlates with mortality in a intubated population of trauma patients. This is both in the hospital and pre-hospital setting. However, what is not known is the predictive ability of ETCO2 in a broader trauma population, being both intubated and non-intubated patients. Our hypothesis is that pre-hospital ETCO2 values would be predictive of mortality in intubated patients, that's via the ILVC, and non-intubated patients via the nasocapno cannula, and would outperform systolic blood pressure and shock index. Our methods is a prospective observational study with the Denver Health Paramedic Division, 2 level 1 trauma centers. That's Denver Health and University of Colorado. ETCO2 was measured by either a nasal capno cannula or an inline ventilator circuit device. And paramedics were asked to place patients that they deemed to be at risk of serious injury on the appropriate capnography monitoring device. This is a picture of me. I learned that one receives a stern warning when standing on top of the ambulance. Our patient population included any adult patients sustaining a primary injury transported directly from the field with at least one pre-hospital ETCO2 value. We then calculated receiver operator curves, and ALROC values were compared for lowest pre-hospital ETCO2 to systolic blood pressure and shock index. The Uden index was used to define optimal cutoffs, and statistical significance was determined to be a p-value less than or equal to 0.05. Moving right into our results, we had a largely young male population, as with most trauma studies, and we had a moderate to severe injury severity score of 13. We had a massive transfusion rate of about 6% and a mortality rate of 10.8%, and 23.8% of our patients sustained penetrating injuries. ETCO2 values were obtained via inline ventilator circuit a minority of the time, so that's only 11.5%, but the majority of the time, these ETCO2 values were obtained via nasocapno cannula. Our biggest conclusion after analysis was that minimum pre-hospital ETCO2 is a significant predictor of mortality, as you can see via the area under the curve indicated by the red arrow. It also significantly outperforms systolic blood pressure and shock index in this prediction. Our Uden index here was 22, with a positive predictive value, as you can see, of about 27% and a negative predictive value of 95. After looking at this mortality population, we wanted to look at a more specific indicator of bleeding in our overall cohort. So we looked at massive transfusion. And what we found is that minimum pre-hospital ETCO2 was a significant predictor, again, of massive transfusion, and also outperformed systolic blood pressure and shock index, again, indicated by the red arrow. The Uden index here was 23, positive predictive value about 16, and a negative predictive value about 98%. So after looking at the overall cohort, we wanted to analyze the data obtained only via nasocapno cannula. What we found here was that, again, nasocapno cannula was a significant predictor of massive transfusion. That ALROC was 0.82, and was a significant predictor of mortality. Of that ALROC is 0.71. It outperformed systolic blood pressure and shock index, though this wasn't to a significant level, a statistically significant level, likely due to the low outcomes of interest in these subgroups. Our study did have some limitations. This reflects a purely urban EMS system. Fortunate most days to be minutes from a level 1 trauma center, and our transport times are incredibly short. There was also a pretty significant global supply chain issue that hindered our ability to collect data. We went weeks and sometimes months without the ability to actually obtain nasocapno cannulas. We also acknowledge there's a possible selection bias of enrollment of patients in trauma triage, given the fact that paramedics are consistently deeming which patients are at risk of having severe injury, though this is a regular practice of paramedicine, and so we think this is probably limited. In conclusion, pre-hospital ETCO2 does give us valuable insight into severity and shock in both intubated and non-intubated patients. This is particularly important given the fact that we continue to make transport decisions, we can interpret resource allocation, and as we continue to push the curve with pre-hospital interventions like TXA and blood products, it can make a more informed decision. This warrants further study into a large multi-institutional trial. So thank you to my co-authors and to my mentor, Dr. Campion, who answered my 1 trillion questions. I promise to pay it forward to another medical student one day. Thanks to the Denver Health Paramedic Division for their enrollment process and for our funders. Thank you.
Dr. Tom Schruppel from Colorado Springs is our invited discussant.
Excellent. Thank you very much, Dr. Kops, Dr. Albrecht, members and guests of Southwestern Surgical Society. What an excellent topic for discussion, and I appreciate the timely submission of the manuscript. This has the potential to identify patients early with a non-invasive technique for us to figure out who's injured and to what level of severity. I won't re-sum up the data because I have several questions. Your data includes patients both with nasal cannula capnography and inline vent circuit capnography. how do these measurements compare? The variance with inline measurements may be up to 10%, which is a significant chunk, and I suspect the nasal cannula capnography variance is much higher since it's not a closed circuit. Are you concerned this may skew your results? Nearly a third, actually over a third of your patients have missing ISS, meaning they're probably not really trauma patients. Does this mean, or excuse me, how do you verify injury with no calculated ISS? I know you said at suspicion of trauma, but I'm just concerned we're looking at medical patients here, which doesn't mean they're not sick, but then how does that apply to the trauma patients? And should we have even included these likely medical patients in this study about trauma? And then you mentioned again how you'd use this, especially by pre-hospital TXA and transfusion, but aren't you already doing this in patients you're worried about? So how does the end-tidal CO2 level really change this? And lastly, this reminds me of the Hutchinson monitor, the STO2 that we used to put on the thenar eminences. And some of the people with gray hair in here are nodding like me. And I think Dr. Margulies actually even published a study on that I looked up. So that has fallen out of favor based on his study. Where do you see this going? And is this something we're going to use in the future? Again, excellent job, fantastic presentation for your first meeting. We would have thought you were a seasoned pro. Congratulations.
Well, thank you very much for your questions and particularly for getting them to me ahead of time since I had not heard of the Hutchinson thenar eminence device. So to start with the variance in the data, with any technology, we are going to see some variance, and we don't think that capnography is we think capnography is going to have variance like any technology. Though we are mindful of this as we move forward, and we think that it is prudent for us to verify these findings, especially like the Uden indices in a larger multi-institutional study to ensure that that's not the case. As far as the missing ISS score, this is a reflection of the practicality of the study. We had paramedics place patients that they deemed to be at serious risk of injury. So this was a primary traumatic injury mechanism to which we were called. And as much as we don't like to admit it, sometimes we're wrong and those patients are actually not injured. And I think that is a direct reflection of the practicality of putting these patients on ETCO2 in the field and being able to have another objective piece of data to look at when we are trying to decipher through, is this a hemorrhaging patient? As far as implementation, I think this serves as implementation in the field, and aren't we already implementing these things, TXA blood products? I teach my paramedic candidates and students, we treat patients, not numbers. And I think that this is just I talk a lot about being like a master puzzle maker. This is just another piece to a larger clinical picture when being a paramedic, and I'm sure one day when I'm a doctor as well. And so this is, we feel that this is widely implemented into the pre-hospital protocol. We feel that before this is implemented into pre-hospital protocols, we do need to perform a larger multi-institute trial again to find those lower numbers. Like, is 22 or 23? Where exactly is that number as far as patients that need interventions and don't? I am not part of a system that carries blood products or TXA. And I think that's probably, again, a reflection of the urban EMS system and our proximity to the hospital. And again, looking at rural and urban EMS in another trial would be a great option. And then in regards to the STO2 and ETCO2, I think this answer is twofold. First, and less significantly, is that ETCO2 is a central measurement of lung perfusion, where my understanding of STO2 is that it's a peripheral measurement and could be affected by things like vasoconstriction in a cold patient or peripheral artery disease. But secondly, and more significantly, is that ETCO2 is already being implemented on the ambulance. And so taking a bunch of paramedics and training them on a new device and then buying the device, I can already see the obstacles that my command staff is giving me in trying to implement something like that. And so I think using ETCO2 is something that is basically repurposing a tool that we already have and data that we're already obtaining. Thank you again.
Hi, Dan Margulies from Los Angeles. Great study and well presented. Thank you. Just a few quick questions. It's probably in the paper, but I didn't see any data on what the actual numbers were. How low were these end-tidal CO2s So that's the first one. On average, how low was it? And the second question is, was there a cutoff that correlated with mortality as opposed to the receiver operating curve? Did you come up with a number that if it was, such and such, that it correlated significant with mortality? The third question is, when did these patients die? Was this early on or later in their course, or were they all dying of a hemorrhagic shock right away? And then lastly, the lowest number you got, I presume that's what you were using, was that always the first measure that you took, or did it subsequently get reduced and the lowest number later than the first one? Thank you.
Yeah, thank you for the questions. As far as how low was it, I think this also leads into the second one with the correlated. That was the Uden index we looked at. So we don't learn a lot about the Uden index in paramedic school, but we had basically found that anything, so for mortality, it was less than 22. So any ETCO2 value less than 22 millimeters of mercury was considered to be in the outcome of interest. And so that would be the quote unquote cutoff as far as the number that we would find to be the most significance for mortality, and it was 23 millimeters of mercury in massive transfusion. In regards to mortality and when did they die, we did not pull out that data. It was just, we chart reviewed months, years later and kind of just found that it was mortality, yes or no, but would be something that would be good to look at. And then as far as the lowest number being the first number, we did not look at this, but in my practical experience, I would say the answer to this is probably no. We use a LifePak 12 and it is constantly sampling. And so when you upload that data, it gives you like 30 of them. I would venture to think that the lowest one is not always the first one. That'd be more coincidental if that happened. Thank you.
Great talk. One question real quick. Is there a way to look at the trend of the end-tidal CO2 and predict how that affects outcome? Because whereas systolic blood pressure, you take it, you wait 5 minutes, the next one's maybe a little lower, you wait 5 minutes, the next one's really low. Whereas end-tidal is almost like having a line, like you can actually watch your patient bleed out and then watch the end-tidal drop. Did y'all look at the trend or anything?
We did not look at the trend, but that is a great suggestion. Thank you.
Our last paper of this session is Tissue Plasminogen Activator Challenge. Thromboelastography is most accurate assay in predicting the need for massive transfusion in hypotensive trauma patients. And the presenter is Jessie Yang. Yang.
Thank you so much for the introduction. Hi, everyone. My name is Jessie Zhang. I'm a second-year medical student from University of Colorado School of Medicine. And I would like to thank Southwest Surgical for this opportunity to present our work. So we are grateful for a number of industry partners who make coagulation devices, and we're also thankful for several federal grants. As a bit of background, the peak time of trauma death from hemorrhage is 2 hours. Patients arriving to the emergency department with severe trauma often have trauma-induced coagulopathy and are at increased risk of bleeding and therefore massive transfusion. However, existing predictors such as trauma-associated severe hemorrhage, assessment of blood consumption, shock index, systolic blood pressure, and rapid thromboelastography fail to have robust positive predictive values. So TIC, trauma-induced coagulopathy, is associated with hyperfibrinolysis, which results in the depletion of fibrinolytic inhibitors. TPA, or tissue plasminogen activator, added to thromboelastography was a test created by a group to kind of determine or detect this environment of depleted fibrinolytic depletion of fibrinolytic inhibitors before it even occurs in trauma patients by measuring clot lysis at 30 minutes. In a previous study by our group, we also showed that the TPA challenge tag can be completed in as little or produce results in as little as 15 minutes, which is quicker than other clinical scores commonly used to predict massive transfusion. What we also know is that hypotensive patients defined as systolic blood pressure less than 90 are at greatest risk of massive transfusion. And so they would really benefit from this, a better and more accurate predictor of massive transfusion. In addition, patients who develop delayed hypotension while in the ED are also at risk of massive transfusion. And so we're interested to see if the TPA challenge tag can accurately predict massive transfusion needs in patients who are hypotensive at ED arrival or who develop hypotension. And this test has been approved for clinical use in Europe. So we hypothesized that TPA challenge tag LY30 is a better predictor of massive transfusion than existing indices, including AVC, TASH, systolic blood pressure, shock index, and rapid tag LY30 in trauma patients with hypotension upon ED arrival or who develop hypotension within 1 hour. For our methods, we had trauma activation protocol patients who were prospectively enrolled from 2014 to 2020 who underwent TPA challenge tag testing. And we did 2 separate analyses of 2 cohorts, the first being those who arrived with systolic blood pressure less than 90 or early hypotension, and the second cohort being those who arrived normotensive and developed hypotension within 1 hour of injury or delayed hypotension. And we define massive transfusion as greater than 10 red blood cell units given within 6 hours post-injury or death within 6 hours after at least 1 red blood cell unit was given. So area under the receiver operating curves analysis was used to compare the different clinical scores. Unit index was used to determine the cutoffs for TPA challenge tag. And this cutoff has been previously published for the rapid tag LY30 in hypotensive patients. What we found is that out of the 1,157 patients who did undergo TPA challenge tag testing, 18% had early hypotension and 11% had delayed hypotension. And as expected, patients requiring massive transfusion had more severe injury reflected by the new injury severity score and lactate levels. So apologies for the busy slide, but just want to briefly make the point that in both groups, early hypotension and delayed hypotension, the risk of massive transfusion was greatly increased by tissue injury and shock. And then also, as you can see here, death was significantly increased in patients who required a massive transfusion in both groups. Now looking at the TPA challenge tag and how it compared to other clinical scores and coagulation variables between the 2 groups, massive transfusion versus no massive transfusion, we see that the TPA challenge tag showed that at 30%, or at LY30, there was actually 66.6% lysis in the massive transfusion group versus the non-massive transfusion group, and similar numbers in the delayed hypotension group. And then when actually looking at the predictive value of the TPA challenge tag and how it compares to other clinical scores, it significantly outperformed other clinical scores with an area under the curve of 0.84. In the early hypotension group. And then in the delayed hypotension group, the TPA challenge tag outperformed all other clinical scores with the exception of TASH. So when looking at the positive predictive value of TPA challenge tag, it also significantly outperforms its counterpart, the rapid tag LY30 at 75% versus 46%. The rapid tag traditionally or historically has had really good negative predictive value scores, but low positive predictive value scores. And you see here that it's also the positive predictive value is also increased in the delayed hypotension group at 65% versus 50%. And the TPA challenge tag also retains a strong or robust negative predictive value score. So in conclusion, of patients arriving hypotensive to the ED, 1 in 3 required massive transfusion, whereas 1 in 6 with delayed hypotension required massive transfusion. We found that the TPA challenge tag is the best predictor of massive transfusion in early hypotension patients with a positive predictive value of 75%. And for patients who have delayed hypotension, the positive predictive value was 65%. And overall, we've found that we know that this is a quick, cost-effective, and physiologically relevant test for prediction of massive transfusion in hypotension patients. And we also know that goal-directed resuscitation using TEG can significantly decrease mortality in massively bleeding patients when compared to conventionally used labs. And with that, I would like to thank the co-authors, my mentors, Dr. Hunter Moore, Dr. Ernest Moore, Dr. Swaya for statistical analysis. And I will take any questions.
Our invited discussant is Dr. Walter Biffle from the Scripps Clinic.
Hi, congratulations on the presentation. Very nice. I don't think anyone would disagree that massive transfusions protocols save lives. The peak time to trauma deaths from hemorrhage is 2 hours, so timely initiation of massive transfusion is critical. Knowing when to stop is also important to avoid wastage of blood products and adverse immune or inflammatory consequences of said blood products. The Denver group, and specifically Hunter and Jean Moore, provided a great deal of data and guidance on trauma-induced coagulopathy and its treatment. And this latest contribution indicates that TPA challenge tag is the most accurate predictor of mass transfusion in trauma patients arriving hypotensive and offers early recognition of the need for mass transfusion in patients arriving normotensive but becoming hypotensive. I won't rehash all the data, but just jump into the question. So my bias is that early activation of mass transfusion is critical. Now, the authors write that this assay can be completed faster than other scoring systems currently in use. Now, the ABC score just requires some vital signs and a FAST exam. They cite the previous paper, viscoelastic tissue plasminogen activator challenge predicts mass transfusion in 15 minutes. But as I read the methods, it says that the assays were done within 2 hours of arrival. The army of researchers trained in this technique take the blood off and do aliquots. And then once the timer on the test starts, you've got an actionable result within 15 minutes. But I would ask, I think I know the answer to this question, but are you using this test to decide to activate the massive transfusion? It seems like it's a little long. Mortality after the in the patients who need a mass transfusion is very high, 56% in the hypotensive group and 85% in the group that was not hypotensive on arrival, but became hypotensive in the ED. Now, I noticed in the table that presented these data with the delayed hypotension patients, the field blood pressure was on average 74 millimeters of mercury in the group that required a mass transfusion. So do you consider activating massive transfusion based on data you get from the field, or is it the presenting vital signs? What was the time to initiation of massive transfusion in all these subsets of patients? And yeah, that's all for that. Now, in the aforementioned paper on the 15-minute assay, it was the JACS paper from 2017, I noticed that the definition of massive transfusion was greater than 4 units of red cells per hour or death within 6 hours. And in this paper, you've got a different definition, greater than 10 units within 6 hours or death within 6 hours. How does the predictive ability of the test vary looking at these 2 different endpoints? And how well does this test predict the overall need, overall transfusion volume or death in the massive transfusion patients? And finally, you pointed out that the test is approved in Europe, but in the manuscript, it says it's not approved for use in the US. There's a lot of logistical challenges to implementing this. And I know that my hospital, we wouldn't be able to pull this off. So it's a nice demonstration that this is the best predictor, but what should we really be doing at the bedside to decide to initiate massive transfusion? Again, congratulations on a great project and great presentation.
Thank you, Dr. Biffle. Those are really great questions, and I appreciate you being my discussant. So for the first point that you made, I think it's a really, really valid point. The tests can produce results in as little as 15 minutes, but really sometimes it is acquired in a much longer time span than that. And the sample is usually viable for 2 hours. So sometimes that does occur. It's too bad that the tag itself cannot be used in the ambulance given the mechanics of the cup and all of that. So we would not be able to carry out that test there. But I think that like that previous paper that you cited, the time to maximum amplitude or clot strength is a good kind of replacement for the indication of whether or not LY30 would be elevated. But I think a lot of this is up to clinical judgment and experience to the physician and whether or not they should activate massive transfusion sooner. I do think that, like you mentioned, possibly the ABC or even TASH could be used instead. But But I think overall TEG is really valued to be run alongside so that we know how to direct our resuscitation once we have the data there. And know like what blood products to give. For your second point, the definition of massive transfusion for blood cell units within 1 hour versus the 10 within 6 hours. 10 within 6 hours. Yeah, that's a really great point. I actually noticed that recently, and I haven't gotten a chance to talk to Dr. Sawaya and see if our analysis we can actually go back and see those values instead. In a paper by a group in 2018, we did establish that the definition of 4 red blood cells within 1 hour actually catches more patients in need of massive transfusion rather than the 6 hours. But I do still think it's a relevant time point, the 6 hours, because the majority of patients, 72%, die within that time frame. And then also the distribution of how many units of blood products are given within 0 to 6 hours is actually pretty spread evenly. So within the first hour, it's about a third of patients are given red blood cells. But by third hour, there's also about a third of patients who are given at least 1 red blood cell unit. So I think 6 hours can at least help us minimize, like you said, wasted blood products, decreased risk of interaction or reactions that we don't want. But that's definitely something I'll look into to explore. And then the third point, so that is really the real question to all of this research. And my understanding is that there are a number of companies who have submitted approval or submitted requests for approval of this test for clinical use in the US. So to be determined, but I think for now, it's really valuable that centers are using RTEG and training clinical workers how to use this machine so that when this test does get approved, we can easily add in the TPA to the TEG.
Thank you so much. Y'all use this study mainly to predict MTP, which may or may not be a fair question. Traditional TEG is a qualitative study of our clotting matrix. When you add TPA, you add an accelerant. So you basically make this a quantitative study. Are y'all looking at data on what quantitative things we need to replace using this outcome? In other words, is it more FFP? Is it Kcentra? Is there something else we need to be adding to patients who have a quantitative deficiency?
That is a really good question. I would have to look into it. But yeah, you're right. It is definitely a quantitative measure, really just to reproduce that hyperfibrinolytic environment. But I'm not sure. I think I would imagine more use, I think in a previous paper, of cryoprecipitate and FFP within the first hour for those patients.
All right, nicely
Thank you so
done.
much.
They give you a chance to
Thank you.
finish.
Thank you.
Yeah, round of applause. All right. So, you want to take it?
Sure. So next we have the mini oral presentations and a simultaneous break. So somewhere in there, go have coffee
There are,
and
yep,
and
across the
goodies.
way.
But
Yep.
the mini orals are over in the kitchen and library, which is across the way. And then we're back here at 4 o'clock for session 2. So
There are 4 simultaneous mini oral sessions with professors. So, let's go hear some of the excellent work that's been done. Thank you very much. So,
tomorrow